Hello. Today's lecture on EKG basics will cover waveforms, segments, and intervals. The learning objectives are to recognize normal waveforms and know what physiological event each represents, to identify intervals and segments on the EKG, and to understand basic conceptual significance of abnormal intervals. Here's an example of a normal EKG. If you are an EKG reading novice, all of these lines and squiggles may be intimidating at first. We'll be learning about the different lines or leads in another lecture. However, it is probably rapidly apparent that there exists in the EKG a specific repeating pattern boxed off here. It typically consists of a very tiny wave, followed by a spike, and then a moderate-sized wave. This repeating unit represents a single cardiac cycle, and understanding it will be the focus of this lecture. So here is that repeating unit up close. Those three deflections of the line are known as waveforms. Waveforms are caused by changes in voltage as measured between 2 points on the body. Each waveform represents a discrete electrophysiological event in the cardiac cycle. The first waveform is called the P wave, which represents atrial depolarization. The tall, sharp spike is called the QRS complex, which represents ventricular depolarization. The third waveform is the T wave, which represents ventricular repolarization. Finally, there is on rare occasion a fourth waveform after the T wave, which is called the U wave, and which is not seen in this particular example. The cause of the U wave is not entirely known, and we'll discuss it more in a future lecture. Waveforms can be described according to a variety of characteristics. They include duration. For example, an unusually long P wave may be a sign of left atrial enlargement, or an unusually long QRS complex may be a sign of conduction block in either the right or left bundle branches. Amplitude. An unusually tall P wave may be a sign of right atrial enlargement, or an unusually tall QRS complex may be a sign of ventricular hypertrophy. And morphology. An inverted P wave may indicate an origin of a heart rhythm other than the sinus node, or an inverted or biphasic T wave may indicate ischemia. A quick word more about the QRS complex. The complex can actually be broken down further into the upwards or positive deflection known as the R wave, the preceding downward or negative deflection known as the Q wave, and the following negative deflection known as the S wave. There are some conventions regarding labeling of the QRS complex, of which you will need to be aware. First, you'll notice that in this example, the Q and S are written in lowercase, while the R is in uppercase. That is not based on whether they are positive or negative, but rather whether they are subjectively large or small. In shorthand, one could label this complex as lowercase q, uppercase r, and a lowercase s. Let's look at three more examples. In this case, the initial negative deflection is very prominent, so there is an uppercase Q followed by a lowercase r. As there is no S wave following the R wave on the EKG, the S is left off the letter-based designation. In this case, there is no Q wave prior to the R wave, so that letter is left off the designation this time, and as the R wave and S wave are both equally prominent, they are both written in uppercase letters. In the situation where there are two positive deflections separated by a negative deflection, the first positive deflection is called the R wave, the second positive deflection is called the R prime wave, and they are separated by the S wave. In the event that the downward deflection separating the two peaks doesn't actually dip below the baseline, some people would refer to the complex as a notched R wave instead of an R/S/R prime complex. Finally, although it is not shown here, in the event that the QRS complex consists only of a single, purely negative deflection, it is known as a QS complex. This all might seem a little tricky at first, but will quickly become second nature after minimal practice. Some of the details as to why the QRS complex may look the way it does in specific situations is described in more detail in the lectures on bundle branch blocks and ventricular hypertrophy. Now let's return to the full set of waveforms and even include a little bit of a second waveform set to assist with the discussion of segments. Segments are lines which connect waveforms. They are simply named based on the two endpoints. For example, this line connecting the P wave and the QRS complex is the PR segment. I have no idea why it's not called the PQ segment, which would actually seem more logical. The line connecting the QRS complex to the T wave is the ST segment. The point at which the ST segment ends and the T wave begins is often hard to determine precisely, but luckily its precise location is of no relevance to EKG interpretation. The line connecting the T wave to the following P wave is the TP segment. The TP segment is important because in the absence of a U wave, it is the part of the EKG that is least likely to be affected by pathology and thus serves as the reference point against which deflections of the other segments and waveforms can be measured. It is sometimes referred to as the isoelectric point of the recording. The only characteristic typically used to describe segments are morphology, including whether or not they have positive or negative deflection as compared to the TP segment. For example, negative deflection or depression of the PR segment can be seen in pericarditis, while either positive or negative deflections of the ST segment can be seen in a variety of conditions such as ischemia, myocardial infarction, conduction blocks, and ventricular hypertrophy. Next, we have the intervals. Intervals are durations of time that include one or more waveforms, plus or minus one or more segments. For example, the PR interval is the sum of the durations of the PR wave and the PR segment. The QRS interval is equal to the duration of the QRS complex alone. The QT interval is equal to the sum of the durations of the QRS complex, ST segment, and T wave. And finally, although not often talked about in the same context as the other three intervals, the RR interval is the duration of all waveforms and segments within one cardiac cycle. As already mentioned, intervals are only described based on the duration, so it would make no sense to describe an EKG as showing depression of the QT interval. It is critical to basic EKG interpretation to know the normal ranges of these intervals. The normal PR interval is 120 to 200 milliseconds. As the PR interval represents the normal delay in conduction within the AV node, a PR interval shorter than 120 milliseconds implies an abnormal electrical conduction between the atria and ventricles, which can bypass the AV node. An interval greater than 200 milliseconds implies delayed conduction through the AV node, usually caused by either age-related degeneration of the node, medications such as beta blockers and calcium channel blockers, or excessive input from the vagus nerve. The normal QRS interval is less than or equal to 120 milliseconds. An interval greater than 120 implies an abnormal sequence of ventricular depolarization or excessive ventricular mass. The QT interval is a little tricky since the normal range is very dependent upon heart rate and mildly dependent upon gender. As an approximation, it should be no more than half the total RR interval. A prolonged QT interval is indicative of a delay in ventricular repolarization, which usually places the patient at high risk of a dangerous arrhythmia called torsade. Both the QT interval and torsade will be discussed in more detail during upcoming lectures on ventricular tachycardia and congenital arrhythmogenic diseases. The normal duration for the RR interval isn't listed here as it's a function of heart rate, and normal heart rates will also be discussed in a future lecture. Finally, there is one more component of the waveforms of which you should be familiar. The specific point where the QRS complex connects to the ST segment is known as the J point, J for junction. Identifying the J point will become important when distinguishing acute cardiac ischemia from a normal variant. That concludes this lecture on waveforms, segments, and intervals. The next lecture will discuss EKG leads.